have to say, I think we all want to thank Dr. Vez and the board for really an excellent organization for the meeting, and I know how much time and planning that takes. So it's a pleasure to be here again. And what I would like to do is just give you a small rundown about the ASAP conceived and funded trial that many of you know about, some of you may not know about. So Tim George and I are the PIs, and it's entitled Outcomes in Patients Undergoing Surgical Intervention for Chiari Type 1 Malformation with Syringomyelia. And so, as you know, as you've noticed from the previous talks, that there are major controversies in everything that's related to Chiari, which symptoms are involved, which surgeries are needed. There is no evidence to speak of making one surgery better than the other, or making one diagnostic criterion better than the other. And randomized surgical trials, which is really the gold standard, are very expensive, very difficult, and ethically and logistically almost impossible nowadays to do. You can't randomize a very symptomatic Chiari patient to surgery versus no surgery. It's just not feasible. So the objectives of this study was not to show efficacy of one surgery over another, but to demonstrate feasibility, which means that before the NIH would fund a multi-million-dollar clinical trial, they're going to say, well, can these centers come together? Can they gather data objectively? Can they come up with endpoints objectively? And if you can demonstrate that you can do this, then we will fund you to really study a question. And so this is what a pilot trial is. This is what this is. So we're talking 80 to 100 patients. It's not going to give a major scientific answer. It will show feasibility and give us a hint of where the answer is. And so ASAP, through a survey of its membership, decided that they wanted to fund a trial of this sort, which would be the first of its kind in the US, and led initially by the late Marcy Spear, and I happened to be on the committee. We had a survey that went to all the ASAP membership. What is your priority? What would you like the first question to be? And almost uniformly, most people wanted to know which surgery is best for Chiari 1 malformation plus or minus syringomyelia. And so the study question was, when you take these three different types of surgeries, bone alone, bone with dura, bone, dura, and tonsillar shrinkage, is there one that seems to be better than the others? And again, it's a pilot study. It's not going to answer the question scientifically. It will show that we can answer it. It'll give us a hint of the answer, and it'll lead bigger institutions to fund us or to fund others to have a trial. So the details is to collect all clinical data from several centers, operative, diagnostic, and then results, but without telling the surgeons what we would like them to do. So they follow their own clinical routine and everything, and then we gather the data prospectively. In order to optimize things, we wanted to first have this backed up by a major academic institution, and we talked to the Senior Society in Pediatric Neurosurgery, the ASPN, and they were glad to sponsor this trial, more morally than anything else. You're the only ones that have given money for this trial. We wanted a uniform collection of data through an electronic database, regardless of which center is involved. We wanted to have good statistics, so we recruited John Kessel, who is by far our best statistician in pediatric neurosurgery, and he's run the best trials in pediatric neurosurgery were run by him. So he helped us design it. We wanted a crisp endpoint. We couldn't just say headaches, because as you've seen from the previous talks, and I think Bob Keating highlighted it really well, is it posterior headache? Is it anterior headache? Is it How do you know there is not migraine, anything like this? So the only really objective endpoints is syringomyelia. You see it on the scan, it's either there or it's not there. It's either smaller or it's not smaller. Now that doesn't necessarily give us any major insights on Chiari without syringomyelia, but it gives us a hint of what these operations are doing. And then we wanted unbiased physicians to really look at all these studies and assess the results. And we have a committee of 3 that will be doing that. We wanted to eliminate bias. So at the beginning, we made a rule that no ASAP board members will be involved in this trial. And frankly, I have to say that this was a mistake. That was my idea because I wanted to be unbiased as possible. But then I realized that the ASAP board members are the ones most vested in this. And they're the ones who would have been the most reliable. And when I found the unreliability factor to be significant with these types of ventures, I started recruiting board members, and Bob Keating was the one I recruited, or we recruited. We wanted geographic diversity, and we got that. We wanted strict criteria, strict. We didn't want Chiari 0 and Chiari 1.5, and we wanted more than 5 millimeter tonsillar herniation. We wanted a syrinx that's well defined. We don't want associated abnormalities. We wanted really clean data so that we can get really clean results. In order to get some input from the ASBN, we ran a different survey for the membership of the ASBN, and this is the representation of all the members. And that resulted in a paper, and there is an acknowledgement for ASAP in this paper, which showed what I've mentioned before, that these are different types of surgeries that are done in the United States by the senior pediatric neurosurgery community. I say senior because the ASBN only takes in senior people. They're all board certified in pediatric neurosurgery. And so less than 5% do bone alone, 90% or more open the dura, half of those shrink the tonsils. And the centers had the same outcome concerns as the ASAP members. So everybody agreed that studying the type of surgery is the way to go. The majority of centers were willing to participate. So we picked 13 centers at the time that we picked on the basis of geographic diversity and surgeons diversity. So we wanted to make sure we have enough centers that did bone decompressions alone as centers that did duroplasty. And we wanted as many centers from the West Coast as the East Coast as central US. So we were hoping for 90 to 100 subjects. I think it's going to end up being 70 to 80, which is great if I can get complete data from all of those. These are the 8 centers that are remaining because out of the 13, 3 centers dropped out. They happen to be the 3 centers that did bone decompression alone, and it was not something I could explain. That's why we went recruiting Dr. Keating and a center in Florida as well. One center didn't give us data, so it was excluded. So we end up with these 8 centers, and we had several updates that we sent on routine intervals to the various centers, and this is the latest update that came out this month. These are the center numbers, the number of patients that were accrued. Initially, we did not want to accrue more than 10 patients per center to give more diversity to it. Then I realized that the IRB works in a funny way, that if someone, let's say, takes on a subject that signs the form, if that subject withdraws, then you can't replace him with a different one. So the number 10 becomes number 7 after. So anyway, we found a lot of kinks along the way that delayed us and that made us reconsider how we're doing things. The bottom line is that we have about 71 subjects that were enrolled, and depending on the center, anywhere between 40 and 87% completion of data collection. And I think the bottom line is that this year is when all the data collection is going to be coming. And now we've become really good at harassing centers to give us their data. And I have to say that the last majority, the big majority of the centers have been really good, and their coordinators have been excellent at following up with us. But it takes an enormous amount of work, because you have to make sure all the MRIs are adequate, that we have the exact MRIs we need pre-op and then post-op. We need 3 months follow-up, 1 year follow-up. Some patients were lost to follow-up, and we had to backpedal, figure out how we're going to get follow-up in those. Otherwise, we lose numbers in our series, and we can't recruit more. So these are some of the problems encountered. Losing patients to follow-up, inadequate or incomplete MRIs, data collection. At the beginning, we were having more of these where the surgeon forgets to get consent from the patient, and then a week later they remember, and that makes it difficult for us to accept that patient. So we tried to be a little bit flexible, but we wanted to be as unbiased a study as possible. Nonetheless, we ended up being able to enroll all these 70 patients. It took about 2 years longer than I thought it was going to take. I think my next study, which will never happen, will take a shorter period of time. So prospective cohort comparison study using objective and uniform data collection. The goal is adequate preparation for a larger study. And in fact, initially we were thinking NIH, but for example, now there is the Park-Reeve registry that a lot of you have heard about. They recruited me to be on the board because of our experience with this, and so it was helpful to them that we had started this center, and they had $2 million, over $2 million of funding, and so they are able to bring in 1,000 patients, which is going to be great, and that's the kind of thing that I hope will happen more and more because of our study and the Park-Reeve. Satisfactory progress so far, now that the kinks have been worked out. The question is how many total patients to recruit. Is 70 enough? So this is something that we're in discussion now to figure out how to end it. So future prospects, this is a body of work based on our initial pilot study. Larger studies could include adults. What I hope is that in addition to the clinical studies, which is what this is, I think the next big study should include specimens from patients, dura, bone, arachnoid, doing biomechanical, non-invasive studies. I think it's very important to expand onto this in the future to try to answer not just what surgery is best, but what is the cause of Chiari and what kind of changes are there, cellular and biochemical changes that are happening because of it. So this is what I've just mentioned now. So collecting tissue samples, collecting data from MRI, and then doing flow study analyses. People who've been involved in the study could certainly go back to these patients. They'll have access to the data and say, okay, I'm going to look at the MRIs now and see if we made a difference from a CSF physiology study. This would really be the first prospective multi-center Chiari and Syringomyelia trial. So that's all I have to say. If you have any questions, I guess I will take them later. Is that what you need, Errol? I don't know where Errol is. If you have a quick question while I pull the next talk, please let me know. Okay, so tethered spinal cord. This is a big topic, and I thought it would be important that you have a really good background of what this is before you start getting confused by why is there potentially tethered cord with Chiari, what is it exactly, and how do you assess it. I need to give you the facts first, and then you can use your judgment to figure out whether your loved one has a tethered cord or not in the setting of a Chiari malformation. So tethered cord syndrome happens in kids who have something called spina bifida occulta, closed spina bifida. So if you look at the embryology of spina bifida, it's incomplete formation of the spinal cord or dorsal midline structures. It will involve the spinal cord, the meninges around it, the bone, and the skin. And you have two types. You have the open spina bifida or myelomeningocele. This is what is termed spina bifida, where the back is open and you can see the spinal cord through a thin membrane. The spinal cord has not closed, there's no bone, there's no muscle, there's no skin over it. This is not what people in this society have. The next is when the skin is closed, but oftentimes there's a marker on the skin that tells you there's something wrong inside. In 40% of cases, there's not a skin marker, so you have to find other ways to diagnose them. So that's the difference between spina bifida aperta or open and spina bifida occulta or closed. So the tethered cord syndrome comes if you're born with spina bifida occulta. And I can show you what this is about. This is what this whole talk is about. Can people with spina bifida present with tethered cords? Yes, they can, but later in life. Because you close this defect at birth, scar tissue forms, and the spinal cord that you just repaired sticks to the surrounding tissues. And that's what causes tethered cord. So this is a scar tissue related, a post-operative tethered cord that was caused by humans. Whereas this one, you were born with it. Okay? So this talk will be about this, but a lot of the same principles also applies to kids with spina bifida who at age 10, all of a sudden, they have leg weakness and bladder problems and back pain, and they have a tethered cord from scar tissue. So, and this will have primarily problems with lower extremities and the bladder, whereas here you have hydrocephalus, you have a Chiari 2 malformation, and you have a lot of other stuff. So how do we make the diagnosis? We can make them based on skin anomalies, like a hairy patch. We can make them based on orthopedic problems, like a club foot or scoliosis, urological problems, bladder incontinence, and neurological problems, leg weakness, numbness, etc., or pain. And the diagnosis is made by MRI. So I'm going to show you just a sampling of what we're talking about here. So let me just check one thing, because usually, oh, okay, so it comes next. So the spinal anomalies that are present, that cause tethering of the spinal cord, cause the tethered cord syndrome, the first and most important one and most common is the tight filum terminale. So the filum terminale is just a string that attaches to the bottom of the spinal cord. And if it's thick and fatty, it could pull the spinal cord or the conus down. And that causes tethered cord. You can see on this image that the conus is down here instead of being up here. And then the filum is very thick. Usually the filum is just very thin. So that's the most common way to have a tethered cord. You can have a fat mass attached to the spinal cord that goes under the skin, makes a lump under the skin. That's called the lipomyelomeningocele. You can have a tract that starts in the skin through a hole, goes all the way in and attaches to the spinal cord and tethers it, pulls it down. That can end in a tumor called a dermoid or epidermoid tumor, which is what this is after you remove it, and that has hair in it. It's just skin tissue that has overgrown in the spinal cord. You can have doubling of the spinal cord. It's called a split cord malformation. And all of these, like I told you, tether the spinal cord, pulls it down. And all of these malformations can independently cause syringomyelia, which is an answer to someone who asked earlier, can syringomyelia come from other causes? The answer is yes. It can come, for example, from a tethered spinal cord. So there's a syrinx in the bottom of the spinal cord called terminal syrinx, as opposed to the cervical or thoracic syrinx that happens with the Chiari malformation. Okay, so the skin anomalies, you can have a hairy patch, a hole in the back, dermal sinus, a hemangioma, usually the thick and raised ones, a subcutaneous lipoma, that's the fat mass I mentioned to you, a caudal appendage, which is like a false tail, they call it. It could be anything. It could have skin, cartilage, bone, a nail. It's just an abnormal outpouching of the back that indicates that there is a problem going all the way down to the spinal cord. And something called atretic meningocele, which is almost like a cigarette burn, like a scar in the middle of the back. And if you look at this one surgically, it follows a track that goes all the way to the spinal cord and pulls it down. This is an example of the tail, and the tails, as I told you, could be could have anything in them. It's to be distinguished from the true human tail, which is the equivalent of what the tails in animals. The true human tail is really the vestigial coccyx, whereas these are pseudotails or false tails that are higher up in the back, and they just don't belong, and they look odd. It could be so complicated. I've seen a picture of a tail that looked like an arm. It was actually an arm coming out of the back. So it could be embryologically very unusual. Fred Ledley put out this statement that I love to show. It says, even those of us who are familiar with the literature that defined our place in nature, i.e. Darwinism, are rarely confronted with the relation between human beings and their primitive ancestors on a daily basis. The caudal appendage brings this reality to the fore and makes it tangible and escapable. But this is not the true human tail. This is just an anecdote, I think. Bony anomalies, you can have subtle vertebral anomalies, scoliosis, obvious foot asymmetry or club foot, or very subtle foot asymmetry. So we have to really examine the patients well to know if there's a difference between the feet. Clinically, we talked about this a little bit. They present with sometimes visible skin and orthopedic anomalies. They can have progressive scoliosis because of damage to the spinal cord that's being pulled down. You can have neurological deficits later in life. And you can have pain, either back, perianal pain, perigenital pain. There are a variety of manifestations. How about in adults? You could have slow deterioration with age. For example, if a lipomyelomeningocele is not closed at birth, over the first 5 years, you may go from normal bladder function to abnormal bladder function. This has been published years ago by your leader, Bob Keating. There is evidence of progression even into adulthood if these are not repaired. Acute deteriorations in adults, that could be caused by G-prides and jarring. I know Errol mentioned the issue of jarring earlier, and that applies to tethered cords as well, or it was Andrew, I think. Motor vehicle accidents, sudden flexion. Also, I've seen 2 patients who, during childbirth, because they're placed in the lithotomy positions, legs up, stretched the spinal cord, and one of them developed numbness all the way down to the knees. And they thought it was the pudendal block, that you give for the episiotomy, but then, the pudendal nerve does not give you sensation all the way to the knees. So she had a tethered cord that was that had not been found before. The results of surgery are decent. There is definite stabilization of symptoms, means lack of progression, further progression of symptoms. Whether the neurological deficits improve or not depends on a lot of factors. What kind of deficit it is, how long it's been there. And you can imagine if you wait long enough, you may not be able to reverse some of these problems. Pain often improves. These are a couple just illustrative examples. So that's a lady who was born with a hole in her back. The hole went into a track, went all the way into the spine, the spinal cord, up and attached to the spinal cord. So that not only did that cause tethering of the spinal cord, but because there's a hole that communicates with the spine, that's a high risk of meningitis. And there are people who presented with abscesses and pus in the spinal cord because of tracking of bacteria through. And you can see here, this is where the hole is, and that's the track going all the way to the spinal cord. This is the dermoid that I've shown you before. This is on the MRI, you can't tell that there's something this complicated. This is all scarred, calcified, hairy, keratin, skin tissue that has grown and grown over years and caused this lady to start having problems in adulthood. This is what a lipoma or fat mass over the back is. If you have a fat mass in the midline of your back, there's a problem, and the problem is that it goes all the way in and attaches to the spinal cord. And this is what it looks like. So that's a cutaneous stigmata of Spina Bifida occulta or tethered cord syndrome. And then finally, I thought you would enjoy this video because that's what a syrinx looks like in the operating room. So this is, I don't think this is the same syrinx that you see in the picture, but that's what it looks like, and in this particular case, we had to put a stent in it. This is a boy that came in with a hairy patch with asymmetry in the legs, and if you look at the x-ray, it shows a bony spicule here, and that was separating the spinal cord in two. That's a split cord malformation that also causes tethering of the spinal cord. Now the hairy tail is an interesting phenomenon. If you know your Greek mythology, you find that there's fawn, and the fawn's tail, which is the hairy tail, you wonder what that was all about. And there's a pediatrician at our institution that published this amazing paper in pediatrics. He's my kid's pediatrician, and he's just one day thought about this, and he said, well, fawn is known to be wanton and lecherous, unhappy in love, part human and part goat. And then he started figuring out, well, why is he part goat? Well, what are goat legs? Goat legs, the calves are progressively thinner, they rise on their toes to walk, the feet become rigid, they lose flexibility, so that's a spastic individual who's losing bulk of muscle in the legs, lose sensation in the feet, lose architecture, start clubbing the feet, trophic ulcerations in the toes, thick layers of callus and scar, and the gait more and more spastic. If that doesn't describe a tethered cord patient, I don't know what does. And so, even back to the mythology, you start wondering where these are coming from. Now, what about Chiari and Tether Cord? I only have 2 slides on this because it's a highly controversial topic that I think, it's a whole new session, a whole other session. The problem is that we just don't know enough. What we do know is that the vast majority of pediatric neurosurgeons don't really see an incidence of tethered cord with Chiari 1 malformations. Now, what is it that's been described in the literature? Before I tell you what's described, I'll tell you what a typical standard tethered cord definition is. The conus might be low, the phylum is thick and has fat in it. You can see the fat phylum here. Usually, it's been shown that if you meet 2 of these 3 criteria, then you probably have a tethered spinal cord, okay? So the occult tethered cord, which has been, we've been told by some that are associated with Chiari malformations, don't have any of these criteria. So they come in with, let's say, bladder dysfunction, and the surgeon cuts the phylum, and they say the bladder gets better. And it may well be the case. I just don't know how this is going to be proven. I know that Paolo and his group have done morphometric measurements here to try to figure out if they can, in some ways, have diagnostic criteria for figuring out occult tethered cords. And I'm not sure where they are with their studies, but there are significant controversies with this. But that's really pretty much the extent of tethered cord associated with Chiari malformations, although there is a high association between tethered cord and syringomyelia. So, in conclusion, it's important to make an early diagnosis so that you don't have a loss of function over time. Even subtle midline cutaneous anomalies can be diagnostic or stigmata of spina bifida occulta. Diagnosis is confirmed by MRI. Surgery is essential to help symptom progression, prevent more symptoms from happening. Something I did not touch on is that the spina bifida occulta and open spina bifida are probably genetically linked. Marcy Spear and her group and others have shown that in a family that has lipomyelomeningocele, for example, they have a higher incidence of a second child with open spina bifida, which means there's a familial link, genetic link. And as you may know, the way to prevent open spina bifida is with folic acid supplementation. So the question is, should tethered cord patients, should Chiari patients, should be given folate, and nobody knows. And at this point, there is no proven association between tethered cord and Chiari-1, but there are controversies, there are studies going in large centers, and hopefully we'll have an answer soon. Thank you very much.